on one more CNS topic, that is general anesthesia and local anesthesia. So general anesthesia is the one which has revolutionized the way we treat the patients, because under general anesthesia we are able to operate on the patients, and under local anesthesia we can do small suturing, thereby the patient is relieved of his pain. So coming to general anesthesia, what is it? Okay, so general anesthetics are the drugs which produce reversible loss of sensation and consciousness. Okay, so what are the important features of this general anesthesia? So the important features here are the loss of sensation. Okay, the patient should be induced for sleep. Amnesia, that is, you should forget the events which are occurring at the time of this anesthesia. Okay, then immobility, the person should not be mobile so that the doctor can operate on these patients. Okay, then abolition of the somatic and autonomic reflexes. Okay, once these reflexes are abolished means the person will have less pain, and once the pain is less, the patient will be more cooperative to the doctor for its operational procedures. Okay, here we have a concept called as minimal alveolar concentration. This concept will help us to know how much of the anesthetic agent we have to give for a particular patient for any procedure. Okay, so which drug is better? Okay, drug A is better or drug B is better, like that. Which drug we have to use for anesthesia? So here the concept tells that it is the minimum alveolar concentration of an inhaled anesthetic gas that should prevent the movement in at least 50% of the patients in response to standardized surgical stimulus. That means when all these agents what we are using for this anesthesia are something like inhaled agents. Okay, so the volatile liquids are there. We also have the intravenous agents, but commonly we are using this nitrous oxide and other volatile liquids which are given by inhalational route. Okay, so when we are giving the drug by inhalational route, it should be able to do what? That is, at least 50% of the patient should not move their limbs. Okay, like administered in 50% of the patients, the patient should not be able to move his limbs. Okay, that much should be his muscle relaxation. That much should be his analgesia. Okay, that is the concept. So if this is in lighter sense, okay, what actually occurs? Okay, here the patient is awake. Okay, we are taking as the drug is given, the patient will go for amnesia, then sedation, then hypnosis. This is the sedation and hypnotic stage where we are acting. Okay, we actually have different stages like Goodell's classification of anesthesia for ether. Okay, this is in lighter sense. If the anesthesia is further continued, if the patient may go for coma and finally death. Okay, that will be the last stage, that is stage of medullary paralysis. We will see it here. Okay, this stages of anesthesia is based on the ether. Okay, ether is of historical importance, which was used initially. Okay, based on this, Goodell, one of the scientists, has classified this stages of anesthesia. Okay, so what are the stages? Stages of analgesia is there, then the patient will go for stage of delirium or mental confusion. Okay, then the patient will go for a stage of surgical anesthesia. This third stage is very important because we are conducting surgeries in this department, in this particular stage. Okay, in this stage again we divide them into plane 1, plane 2, plane 3 and plane 4. Okay, the common plane where we do our surgeries are plane 3 and plane 4. Okay, in plane 1 there will be rolling of the eyeballs, then in plane 2 we have loss of corneal and laryngeal reflexes, in plane 3 we have loss of light reflex, and finally plane 4 will be dangerous because there will be loss of intercostal muscles action, so that respiration will be ceasing and intercostal muscle paralysis will occur. Finally, medullary paralysis or patient will go for death. Okay, first stage of analgesia means once we have given the injection of anesthesia, okay, and or inhalational gas we have given till the person will regain his consciousness. Once the person has got his consciousness, and he will go for stage of delirium. Okay, in stage of delirium he can go for excitement, he may shout, okay, he may involuntarily defecate, urinate, okay, all these things can be there in case of stage of delirium. Okay, that's why what we do, we take before taking the patient for any surgery, we'll do bowel evacuation. We'll tell after overnight 12 o'clock you should not drink anything or eat anything. Such instructions are given. Okay, that is of nursing importance. Then coming to the actual drugs classification. Okay, so the first group of drugs we are using here are inhalational anesthetics. That is nitrous oxide, cyclopropane and xenon. Okay, nitrous oxide is the most commonly used drug. It has many positive effects because it is the most cheaply available. Okay, here other drugs used are the volatile liquids. Volatile liquids are again the inhalational agents which are given. Okay, these are isoflurane, N-fluorane, CO-fluorane, desflurane, halothane. Okay, we can remember it by the mnemonic he dies. H for halothane, E for ether, E for N, D for desflurane, okay, I for isoflurane, again E for N-fluorane and S for C-fluorane. Okay, intravenous anesthetics are divided again into inducing agents and maintenance agents. All these above drugs which we have studied till now are inhalational drugs. Okay, then we have intravenous group of drugs. We have inducing agents and maintenance agents. That is, induction purpose we have some drugs and maintenance purpose we have some other drugs. Here we have Thiopental sodium, okay, methotrexate, Propofol and Ketamine. Thiopental is the barbiturate group of drug. Okay. Coming to the other intravenous agents that are slow acting agents or the maintenance agents, those are benzodiazepines. Okay, benzodiazepines you have already heard, no? They are sedative hypnotic drugs. Okay, so these drugs are diazepam, lorazepam and midazolam. Midazolam is more commonly used drug. We have also dissociative anesthesia. In dissociative anesthesia we have ketamine. Okay, so the patient consciousness is also maintained but he is dissociated from the surroundings, and where we need the patient cooperation we are using this group of drugs. Neurolept analgesia, okay, fentanyl is a neurolept analgesia where the patient will be taken to a stage of profound analgesia. That means complete loss of pain sensation, and the patient will be cooperative in that stage also. Okay, we are using this dissociative and neurolept as the rarely used drugs where the patient cooperation is needed and consciousness should be maintained, maybe in some of the orthopedic surgeries and bronchoscopies. Okay, coming to the first drug, nitrous oxide. Okay, so nitrous oxide is the most widely used drug. Okay, this blue big steel bottles we are seeing, just that once you go to the OTs or somewhere, you can identify this. Okay, these are potent analgesics. Okay, analgesia means pain. Okay, pain is relieved. Okay, and widely used because it is more cheaply available. They produce light anesthesia. The anesthetic effect of this drug is not that good. Okay, and the muscle relaxant effect is also not that good. But here it produces good analgesia. Okay, and the positive point here is they do not depress the respiratory and the vasomotor center. This respiratory depression is a part of the action of some of the other drugs such as the ether and some other group of drugs, but here that side effect is not there. These drugs are commonly used as a supplement or adjunct to other inhalational agents. Okay, so with nitrous oxide we have one positive effect, that is second gas effect, and one negative point we need to remember are diffusion hypoxia. What is this positive effect? Nitrous oxide being a gas, it can diffuse faster. Okay, so as it can diffuse faster, any other gas which are introduced along with this gas in smaller quantities, it can reach the alveoli. Okay, you know alveoli, what are these? These are the primary functional units present in the lungs. Okay, so it can reach, once you have given it through mask, it can reach the alveoli faster. Okay, so with this positive property, any other gas which is used along with that, such as halothane, N-fluorine, CO-fluorine, which we have studied, they can also attain the alveolar concentration at a higher concentration, which is helpful. Okay, so it can concentrate the halogenated anesthetics which are used along with it, okay, in the alveoli after concomitant administration, and faster uptake will be there. Okay, that is the positive point. Okay, what is the negative point? Diffusion hypoxia. So this nitrous oxide is having high solubility in the blood. Once the operation is over and we want to stop this nitrous oxide and recover the patient back, at that time what can happen? This nitrous oxide can completely diffuse in the alveoli as due to its high blood solubility also, and occupied. Once this nitrous oxide is completely occupied in the alveoli, we need the oxygen for respiration, not the nitrous oxide. Okay, the alveoli will be deprived of the oxygen. So that can what can happen? The patient can go for respiratory distress. At that time, what we need to do is we need to introduce 100% oxygen also. So before stopping this nitrous oxide suddenly. Okay, by introducing the 100% oxygen, we will be able to recover the patient and prevent the patient from going into respiratory distress. Okay. So what are the demerits and adverse effects we can come across with this? One is that diffusion hypoxia, you already know it, we'll study the rest. Okay, we told that it produces profound analgesia but not muscle relaxation. But for operative procedures, we need muscle relaxation also, and also anesthetic effect. So both are lacking in this nitrous oxide. Okay, so post anesthetic nausea, vomiting can be there. Okay, so if the surgery is carried on more than 4 hours or prolonged, there are chances that the patient may have anemia. Okay, and in cases of pregnancy and all, this drug is not safer. It can go for abortion and birth defects can be there. Coming to the Propofol. Okay, Propofol again, it's a agent which is used for daycare surgeries. That means a shorter procedure. The person is taken for surgery in the morning and the patient will be sent to home in the evening. Like very short duration operations, we are using this drug, that is Propofol. Okay, it is a shorter acting agent used for induction and maintenance of general anesthesia and can be used in pediatric patients. In pediatric patients above 3 years, we can use this drug. Okay, and P for P, you can remember Propofol for pediatric patients but more than age of 3 years. Okay, so it is highly protein bound. Okay, the drug which is highly protein bound has prolonged duration of action and also less drug is available for the action. Okay, so just remember, any drug which is bound to the protein for plasma protein for longer time, there will be slow and sustained release of this drug and the drug will be less available for its action. So even though it is short acting, because of protein bond, the duration of action can be prolonged here. Okay, then what are the side effects? The side effects here are pain at the site of injection and the patient can go for hypoxia. Okay, so this transient apnea can also be there and hypotension can be there. This hypotension may be due to the peripheral vascular dilation. So in case of anesthesia, what we will do, we will try to put the patient's foot and elevate it to prevent this hypotension. Have you seen the patient foot and elevated in the wards? Yes? Have you gone to the operation post-operative wards? Huh? Okay, once you go there, you can see that. Okay, the Halothane is again one more good drug which we are using till now. Okay, what are the advantages here? Okay, Halothane again, it is a hepatotoxic drug, but in pediatric patients we can use it. Okay, it is less hepatotoxic in pediatric patients. So it is non-flammable. Okay, it is in comparison to ether which was used previously, it was inflammable gas. That any drug we are using in operation theatre, it should not be inflammable because it should not affect our electric cautery, which is used to prevent the bleeding. Okay, so other negative point here is it can induce the hepatic microsomal enzymes. Okay, in adults, okay, and others. If the drug is used today, it cannot be used for next 1 month, okay, or 20 days, because it is a hepatotoxic drug. Then it is a myocardial depressant. Okay, myocardial depressant, that is, depressive activity is there. And one more negative point here is it can sensitize the heart to the catecholamines, okay, and can cause arrhythmias. Do you remember what are catecholamines? Have you heard this term? In case of general pharmacology, ANS, have you heard this term, catecholamines? Okay, adrenaline, noradrenaline, dopamine, these are catecholamines, endogenously produced amines. Okay, coming to the side effects, okay, that is hepatic damage, you already know, okay. Then transient hepatic damage, that is for short duration of time you cannot repeat the halothane drug, and you can go for, patient can go for hypercapnia, okay. There can be increased respirations, okay. Then it can cause malignant hyperthermia. Okay, it is a genetic phenomenon, not all can get this side effect, okay. Malignant hyperthermia is a pharmacogenetic hypermetabolic state, okay, where state of skeletal muscles, where the person's inhaled will have side effects. There will be increased temperature, blood pressure, all these things. Okay, so malignant hyperthermia, sensitization of the heart to the catecholamines, hypercapnia, hepatotoxicity. 4H of this halothane you need to remember. Okay. Coming to N-fluorine, okay, this N-fluorine used as a replacement for halothane, it has lesser chances of getting metabolized by hepatic microsomal enzyme, so less chances of hepatic toxicity. So it is better than the halothane. Okay, so it is introduced as a replacement to halothane. Only 10%, up to 10% is metabolized by liver, so lesser chances of side effects. Coming to isoflurane, okay, it is again used as a replacement to halothane. Okay, very little metabolism, 0.2% only. So again, very less chances of hepatic side effects. No reports of hepatotoxicity and renotoxicity. We have other drugs, that is desflurane and sevoflurane. Okay, this desflurane is having pungent odor, and pungent odor means that the person may not be having the pleasant sensation while inhaling this gas. Okay, something like ether, chloroform, all these things. When you fumigation will be there, no, that pungent odor will be there. That will irritate the patient. Okay, then patient can go for laryngospasm. Okay, that's why these drugs should be used carefully and sparingly. Sevoflurane, again, it is a chemically unstable drug and is a nephrotoxic agent. Coming to the drug Thiopental sodium, it is a barbiturate group of drug. Okay, it is having rapid onset of action. Okay, it is a intravenously given agent. Okay, Thiopental sodium is a intravenously given agent. Within 1 hour blood circulation time, that maybe like 11 to 15 seconds, the drugs can take the patient to anesthesia, faster induction. Okay, there will not be misery taking the patient faster to anesthesia. So we have to do emergency surgeries. Okay, we can go for this drug, Thiopental sodium. The effects can be terminated by not by metabolism but by redistribution. Okay, so it has the property of high lipid solubility. Okay, once because of this high lipid solubility, what can occur? The drug can diffuse throughout the body fastly, so that the action is terminated faster. But still, after the redistribution also, slowly the drug can be released back into the plasma. So the patient should be hospitalized. Okay, when we are giving this Thiopental sodium, it is mandatory that we are admitting the patient for at least 48 to 72 hours and maintain the patient there in the hospital. Okay. So here, what will happen on repeated administration or prolonged infusion? We can get a equilibrium state where the patient will have enough anesthetic effect. We told as it is highly lipid soluble, it can build up its concentration in the adipose tissue, and the person may be under anesthetic effect for up to 72 hours. Then what are the side effects? Most of this inhalational and intravenous we can get peripheral vasodilatation. Due to this peripheral vasodilatation, there can be hypotension. The amount of the blood returning to the heart will be decreased. Hypotension, apnea and airway obstruction. All these things can happen. Coming to the ketamine. Okay, ketamine is a drug which which is help for dissociative anesthesia. So this drug and nitrous oxide have different mechanism of action. Okay, the mechanism of action here are they act on this NMDA receptors, and most of the other regular drugs they have their mechanism of action with respect to most of them are acting on the sodium channels. But here ketamine it is different in that they act on the NMDA receptors. Have you heard of this NMDA receptor? Okay, so this NMDA receptor they are having a excitatory function in the body. Okay, so action should be activated and all their NMDA action will be there. So we have to inhibit the brain action and all means there will be GABA action. Okay, so NMDA is a arousal like, okay, something like activation of mind, activation of brain. There we have this NMDA receptors. Okay, inhibition of the brain, induction of the sleep and all, we have the action of GABA. Okay, just remember NMDA is the excitatory part, GABA is a so they usually stimulate rather than depress the circulatory system. Here it is an antagonist. Okay, so if excitatory neurotransmitter is prevented means again the person may go for sleep, or here we are using it principle for inducing the anesthesia. Okay, so it is a dissociative anesthesia. The person will be feeling that he is dissociated from the surroundings. Okay, and the patient cooperation can be attained here. Okay, for example, it may be a bronchoscopic examination or some orthopedic surgeries where we need the patient to move the limb or ask him what is happening, like that, where the patient cooperation is needed, we can use this type of anesthesia. Coming to the Neurolept analgesia. Okay, here Neurolept analgesia we are combining two drugs. Okay, what are the two drugs we are combining? One is a droperidol and another is a opioid analgesic, which is more potent than morphine, that is fentanyl. Okay, so it is a combination. Droperidol is a butyrophenol derivative. We use this butyrophenol derivatives as a antipsychotic drugs. Okay, here fentanyl is a morphine-like opioid analgesic. We are combining these two drugs and producing a state of apathy and mental detachment, where the person will feel decreased pain. Okay, and here also sometimes we can get the patient's cooperation. So we got to know so many drugs which are used for this anesthesia. Okay, so after learning all this, we need to know something which is balanced. Okay, so balance means a balance between good effects and balance between bad effects. Bad effects are laryngospasm, respiratory depression, hepatotoxicity, all these things are there. Good effect is good muscle relaxation, good anesthesia. Okay, all these effects are staying under good effect. So we need to balance these things. How we are balancing? We are studying here. This can be short notes for you. What is balanced anesthesia? For sensory, okay, so to perceive is sensory. Okay, for to perceive pain, temperature, all this is sensory. The sensory part is better avoided by the help of this nitrous oxide, opioid, ketamine for analgesia. Okay, and cognitive part, the mental alertness part. Okay, that which produces mental depression, that is produces amnesia and preferably unconsciousness. These are inhalational agents that are Propofol, midazolam, diazepam and Thiopental. Okay, and the motor effect and the person's movement. Okay, the person's movement should also be prevented while giving this anesthesia. So that can be brought about by using the skeletal muscle relaxants. Have you heard of the skeletal muscle relaxants? Yes? Okay? Dituberculine, pancuranium, okay, all these are the mivacurium, atracurium, all these are muscle relaxants. For bronchoscopy we are using succinylcholine, that is one more popular drug. Okay, and learning something about this pre-anesthetic medication, one more short notes. Okay, so pre-anesthetic medication means before anesthesia, what precautions we should take that the patient will not have problems on the operation table. Okay, so pre-anesthetic agents, the patient will be anxious, tomorrow is my surgery, something like anxiousness will be there, that need to be prevented. For that we can use a anxiolytic drug and a sedative group of drug. Okay, so benzodiazepines and barbiturates, these are the pioneers for the sedative effect. Okay, so we can also go for butyrophenones, phenothiazines, chloral hydrate and taralgin. These are rarely used. Commonly drugs what we are using are diazepam, okay, diazepam, lorazepam, all these group of drugs. Then opioid analgesics. Okay, the person may have a lot of pain. Okay, he might have got a road traffic accident. Okay, that the pain can increase the anxiety of the patient. So we need to keep the patient calm. By keeping the patient calm, we can get more cooperation of the patient. Okay, how do we do that? How do we decrease the pain? We can use an analgesic. Okay, profound analgesia is by opioid group of drugs. Okay, morphine, pethidine, and buprenorphine. All these are opioid derivatives. So anticholinergic effect. The secretions of the persons, okay, the respiratory secretions, oral secretions, all these secretions should be decreased. Where we are using this anticholinergic drugs to decrease the secretions, atropine sulfate, scopolamine, synthetic anticholinergics such as glycopyrrolate. Glycopyrrolate is nowadays most commonly used drug for this purpose. Antiemetics, okay, the person after anesthesia can go for vomiting sensation, that will be there, and that is the side effect of most of this general anesthetic drugs. Okay, so we can go for prophylactic and also post-operative anesthetic antiemetic drugs. These are phenothiazines such as promethazine and trimethazine. Okay, we can go for metoclopramide and benzphenamide. Okay, cyclizine you can remember, cyclizine and promethazine, basic group of drugs you can remember.